thanks everybody for coming tonight. I appreciate you coming to learn a little bit about balance disorders and dizziness. So that's what I'm going to be talking about. I'm Cheryl Clarizio, and I've been working for Milford for about 12 years and in this clinic for a long time, and doing vestibular rehab for about 5 years now. So many of you, I'm sure you came here for your own reasons. You either have been dizzy or you know somebody that is dizzy, a family member, and you're actually in the company of some pretty famous people who have also had dizziness and learned how to overcome it. So you're not alone. And as Neil said, if anybody has any questions, please feel free to just raise your hand, okay? So I'm going to be talking about what is dizziness and what is balance so that you can understand it a little bit. I'm going to talk about the anatomy. I'm going to clarify the systems in the body that help us to maintain our balance. And then Sue is going to talk about some specific disorders of the vestibular system and what we do for rehab. Dizziness is a real common symptom. It significantly impacts our lifestyle and our function, and it's among one of the most common symptoms that brings us to go see a physician. In fact, 5 to 10% of the overall visits to the doctor are related to either balance or dizzy disorders. That number goes up. If you're over 40 years old, it's 40%. So it's a pretty important problem. And when people go to the doctor, they report their symptoms. They'll say they're dizzy, they have vertigo, they have disequilibrium. And the way you describe your symptoms to your doctor can really help him to clarify what the cause of your dizziness is. So, if you go in and just say, I'm dizzy, you might be having a sensation of lightheadedness. You might feel faint. You might just feel unsteady. You might go in and say, I'm feeling foggy, dazed, spacey, hazy, a lot of different words to describe that. And you might even feel like you're going to pass out, but what you don't feel usually is movement. Vertigo is that's a whole other category of dizziness, and that's when you're feeling spinning. There's actually a rotational component. You have the perception that you are moving or that the room around you is moving. And that might feel like spinning, whirling, tilting. You might have some nausea and some vomiting that goes along with that. You might feel like you're going to fall. And it's important to know vertigo is not a disease, it's a symptom. So true vertigo indicates a problem in the inner ear or in the cerebellum of the brain. There's a few symptoms that require urgent attention. Those are our red flags. So, if you get a really severe headache that you can't explain, or dizziness that's associated with chest pain or change in a heart rate, that's more urgent. A sudden loss of balance or loss of control of your arms or your legs, that's ataxia. Dizziness that's associated with a loss of sensation, loss of strength, slurred speech. Those can indicate a more serious problem, and they need urgent attention. When people say disequilibrium, that's just a general description for unsteadiness. So what causes dizziness? All right, so we talked about vertigo just a little bit. Vertigo is that sudden episodes of spinning that are short-lived, and they pass, but you feel really bad when you have it, but they do pass. That's usually vestibular when you have that. Vestibular means it's coming from the inner ear, okay? And that people really notice that, especially if they change their head position. So you could have dizziness from a lot of other problems as well. Could be cardiovascular. So if you have a change in blood pressure, so people who are laying down, it is positional, but a lot of it's more related to a drop in your blood pressure. So going from laying down to sitting, or sitting to standing, and then you feel a little bit off for a while. That oftentimes is a blood pressure issue. A few problems with the central nervous system that can cause dizziness. Things like a stroke definitely can affect it. Multiple sclerosis, Parkinson's disease, those are things that can throw your balance off, but they're not coming from your inner ear. Diabetics often have a peripheral neuropathy, meaning that their feet, the distal part of their extremities, they might have pain there, they might have a loss of sensation, burning, so when their foot hits the ground, you're not going to feel what is normal, and it's going to throw you off balance a little bit. And you could have a combination of a lot of these, and we certainly have had people who walk in here who have got, diabetes, maybe a history of a stroke, and they come in with symptoms of more of a vestibular problem. And so it takes, we really need to get a pretty good history to try to figure out if we can help you by treating the vestibular, the inner ear problems. So mostly tonight we're going to be talking about vestibular and a little bit of cervicogenic, which means dizziness that comes from the neck. So why is dizziness an important symptom? Okay, that really lots and lots of doctor visits, lots of emergency room visits. The biggest reason that it's important is because it causes falls. So, and falls are, 20 to 40% of adults over 65 years old that live at home fall, all right? And dizziness, any balance disorder may lead to that. There's a lot of secondary problems that come along with being dizzy. When just having the fear of falling, if you know that you're dizzy or your balance is off, you are going to be afraid of falling, and you might start spending a little bit more time on the couch or in a chair, afraid to get up. Your muscles get tight, your muscles get weak. If your muscles get weak, you're going to have trouble going from sit to stand, trouble getting up and down those stairs, trouble picking things up off the floor, and you just stop moving around, basically. If you do that, you're going to lose your endurance, and if your endurance is down, you're going to have trouble, you're going to get tired with just your everyday activities. And if you're fatigued, then you stop spending time in the community, you stop doing all the social activities that you used to do, and that leads to being anxious and depressed. So it's not good. We need to take care of the dizziness. It's difficult to diagnose. If you go to most people go either to the emergency room first or to their primary physician, and the primary physician is likely to refer you to an ENT, an ear, nose, and throat specialist. And that doctor might do a hearing exam, might run some blood tests, might do an electronystagmogram. That is what it measures eye movement and the muscles that control your eye muscles. And possibly they'll do some imaging of your brain and your head just to rule out anything that's more serious, perhaps a stroke or a tumor. You do need to rule out those very serious conditions. So we're going to now talk a little bit about balance. If anybody has any questions about what I just said, feel free. Do you have a question?
Just one question. You mentioned blood tests. What are they looking for specifically in a blood test that would indicate? Is it hemoglobin? Is it red blood cells?
It could be red blood cells, because if that would be your hematocrit. If that's low, then you're not going to be getting enough oxygen to your muscles, and you are going to have that perception of perhaps lightheadedness. Not so much the vertigo, but more of the lightheaded types of symptoms and the fatigue, the feeling like you don't have strength. Yes? Vestibular refers to the inner ear. VESTIB. It's on the chat. Oh, good. That's all right. No, I love when you ask questions. Everybody asks questions. It makes it more comfortable dialogue. All right, so this is clearly not good balance, but I do want to talk about what balance is, what good balance and normal balance is. It's the ability to maintain your body over your base of support, and we do that by tapping into 3 different systems: the vestibular system, which is your inner ear, the oculomotor system, which is your vision, and the somatosensory system, which is your feet, your joints, your muscles. So information from these systems is relayed to your central nervous system, your brain, and here that information is integrated and it's organized. Take that organized information and it passes that on to the motor system, our muscles, all right? So then the muscles help us to achieve that balance and postural control. Anything that disrupts that process can lead to a balance disorder and dizziness. And again, Sue will talk about some of those disorders a little bit later. This is maybe a more clear picture of how it all comes together, the muscles, the joints, the inner ears, the eyes, and the brain. So good balance also allows us to see clearly while we're moving, and that with a vestibular problem, a lot of times that is impacted. We need to be able to orient to gravity, direction, speed of movement. We need to make automatic adjustments every time we change our activity, every time we change the terrain that we're on. So we've developed some balance strategies. Balance is a huge part of vestibular rehab. And you won't walk into this clinic with that diagnosis without seeing this. At least if you see me or Sue, we'll be having this cushion, okay? And we use this for different balance strategies. It's a foam cushion. You can't see it. Everybody see the foam cushion? So this is one way that we can alter the terrain that you're on and affect your balance. So if we're talking about ankle strategies and hip strategies and stepping strategies, this would be an ankle strategy. If I step on some terrain that is different than the solid floor, I might have you try to do it on one foot. You're right away going to feel your ankle start to adapt and adjust to that surface. You're going to feel you might have to put more weight on the heel, more on the toes, more side to side. And we have lots of different ways of working with this. The hip strategies, just you move up the chain a little bit. Picture yourself if you're in a crowded environment and you're just standing minding your own business and somebody walks into you, all right? You could fall, or you can use your hip strategies and you kind of put your body weight forward or put your body weight backwards, right? Stepping strategies, well, we've all seen that. We've all seen somebody who's walking along gracefully and then they stub their toe or they hit a crack and they lose their balance, but they don't fall, they step. They step out of their normal base of support and they catch their balance. So you really have 3 chances to not fall. What is the vestibular system that I keep talking about? It's all the structures in the inner ear that are responsible for balance. So I have to talk a little bit about anatomy. This is where it gets a little bit technical. Balance is controlled primarily by a maze-like structure in the inner ear. It's called the labyrinth. And the medical term for all the parts of the inner ear that are involved in balance is the vestibular system. So let's see if I can use this pointer here. I'm trying to give you a little bit of perspective with the outer ear. Does it look like an outer ear to you? So if you go to an ENT or any doctor, they're only going to see about as far as the eardrum. So they can't look in your ear and tell if you've got a problem with your vestibular system, because that would be right over here. This whole little, that's the labyrinth, all right? So that just gives you a little perspective. And I even have this one that shows you it's on both sides of your head. So you have 2 vestibular apparatus, one on each ear. So it's the vestibular system is going to provide information to your central nervous system, so you can see the brain in there. That's part of your central nervous system. The brain's got to integrate everything. And the vestibular system is going to provide that information about the position of your head, and it works with those other systems to check and maintain the position of your body when it's at rest and when it's moving. And it helps to keep that focus when your focus when you're moving with your eyes, and that's called gaze stabilization. That's another thing that we do here is gaze stabilization. We'll talk more about that. So there's one of these little vestibular apparatus in each ear. That's more of a close-up. It's made up of 3 semicircular canals, the anterior, the posterior, and the horizontal. and it's made of two otolith organs, the utricle and the saccule. And those together make up the bony and the membranous labyrinth. So the semicircular canals, just to give you a little visual of how they work, it's like little levels in your head, okay? There's a bubble, and it tells you if you're even, all right? Instead of a bubble, what we have are hair cells. And the hair cells are connected to a nerve fiber. So there's fluid that moves through each of those canals, and it bends the hair cells as it moves, and as they bend, it sends a nerve signal to the brain that's proportionate to the amount of movement of that hair cell. Does that make sense a little bit? All right. So the first signal is going to go to the cerebellum of the brain. And so now we've gathered information from the eyes, the joints, the skin, and the muscles. And the cerebellum is going to organize that so that you have some balance in your coordination. The second signal is going to the oculomotor system, and that controls the muscles of the eye. Each canal, each of these semicircular canals, controls a different muscle in our eyes and allows us to focus while you're moving your head. That's automatic, and that's called the vestibular ocular reflex. And that's one of the things that we're going to look for when you come here, is to see if that reflex is intact. So when your head's at rest, the impulses from the right ear are going to be equal to the impulses on the left. If your head turns to the right, the impulses on the right ear are going to increase. They're going to become faster, sending it to the brain. And on the left, it's going to decrease. Okay? So as it decreases on the left, you're allowed to stabilize your gaze. All right? If everything's going really fast, when you turn your head here, you're going to get dizzy. You're going to feel off. Any interruption in that process is going to make you feel dizzy. So the otolith organs is utricle and the saccule. All right, those are called otolith organs, and they detect gravity and vertical orientation and linear movement. So if you think of an airplane or think of an elevator, those are the organs that help sense that type of mobility. And they're similar to the semicircular canals because they do have that fluid in them, and they have the hair cells. But different from the semicircular canals because those detect your head movement. Your semicircular canals are going to tell you if your head is turning right, turning left, tilting right, tilting left, nodding up, nodding down. So each of those canals will have a different purpose. So the difference with the utricle and the saccule is that they have otoliths. Okay, that's what maybe you have heard about these crystals that we have in our inner ear. All right, and that's where the problems start. That's a normal thing to have. It's normal to have these otoliths. It's not normal when they get into the wrong place. So they basically are calcium carbonate crystals, and they sit on top of the hair cells, and they connect to the nerve fibers. And again, the hair cells are going to bend from the weight of the crystals, and when they're functioning well, the impulses from the right and from the left are going to be symmetrical. And the nerve that you see here is the vestibular nerve right here. That's where the information is collected and transferred off to the central nervous system. So each vestibular apparatus is going to push you upright against gravity. If you don't have that pushback, you're going to get symptoms of disequilibrium, dizziness, or vertigo. So you're going to see us use a lot of these. This is my favorite thing, to give everybody a tongue depressor and tell them to go home and make a letter that is clear, because we use this for gaze stabilization. Anybody come here and get one of these? But what you're going to do is you're going to turn. I'm going to show you how that reflex works. If you turn your head to the right, your right ear apparatus pushes your eyes back to the target, and the left ear decreases the signal. So each ear is going to consistently send a signal to the brain. So I turn here, it increases on the right, and I turn here, and it increases on the left. And I can still keep my focus on that A, even though my head is moving. So the vestibular system can even make sense of things that don't make sense. So if you're, for example, if you're on a train platform or even on one train and the other one starts pulling away, you might have that sensation. You might say, well, is my train moving? And the other one is really pulling away. And what's happening is you're going to get that feedback from your proprioceptive, your muscles in your feet and your joints, and they're going to tell you something's up here. And then your visual is going to say, well, I think we're moving. And the tie is broken by the vestibular system, which is going to clearly tell you that you're not moving, the other train is moving. So it overrides that conflict. They really need all three of those systems to work together. But all of it, all that balance information is going to be, this just kind of outlines how it's all working. You get the sensory input from those three sources, integrated by the brain. Your cerebellum is going to coordinate the posture, the movement, and the balance. Your cerebral cortex, that's your thinking center, that's going to try to make some sense of it. And then moves it right along to achieve balance by controlling the different muscles of our body. And so, if anybody has questions, you can ask me, and I'm going to turn this over to Sue, so Sue can talk about what happens when things go wrong.
Okay, well, thank you, Cheryl, for doing such a great job introducing us all to.
We got one question
Oh,
for
I'm
Cheryl.
sorry.
Yes? Can you hear me?
I'm not sure if it's a thought / question. I'm just wondering, like hearing you talk about everything that's going on inside and all the intricate things that go on.
Making you dizzy, isn't it?
It's like, whoa. But I'm thinking in my head, okay, so do we all start out the same? Because some people, you see people on TV, they're on carnival rides, they can, do flips, I don't know how many times, and nothing seems to bother them. So are we more sensitive because of something?
It's a good point, because and it really is what we do with vestibular rehab, is we train and retrain so that you can do things, you can tolerate motion. Think about an athlete, all right? Maybe dancers and gymnasts come to mind, all right? They are not born with the ability to do a pirouette and do 10 of them in a row and then focus. What they're going to do is they're going to do one, and then they're going to do this, or they're going to do one, and they're going to fall on the ice, all right? But if they do practice, 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 the same activity over and over and over again, and that's what we do with our patients. We do the same thing over and over and over again. We'll do a movement. You get dizzy when you go from laying down to sitting up. You're going to come in, and you're going to go from laying down to sitting up many times. Okay? And your body is going to learn to handle it and to tolerate it. Does that answer your question a little bit? So you do have that ability. I mean, babies, they're born with all the apparatus to do that, but they need to work their way up. They don't come out running and flipping. They come out and they start to crawl, they start to roll, and it's all integrated. The vestibular system is part of that.
Any other questions before we?
Is motion sickness part of that?
It is. It is, definitely.
Going on a boat or playing?
It is. There's some very specific things that Sue is going to talk about, but motion sickness is a vestibular problem. And some people do just tolerate motion better than others. So you can train it a little bit, but some of it I think is inherent.
Any other questions? No? Okay. All right, well, thanks again, Cheryl, for introducing us all to the vestibular system. We're going to talk about some specific vestibular conditions that are very commonly diagnosed and that we see commonly here in our practice of vestibular rehabilitation. The first one on our list is BPPV, benign paroxysmal positional vertigo. I see people nodding. People are familiar with it. So benign refers to harmless, not life in the sense of not life-threatening. Paroxysmal means it's a sudden onset. Positional is in regard to it occurs with a positional change, particularly of the head. And vertigo is that room spinning sensation that Cheryl talked about previously. So we're going to do a little bit more talking about BPPV. It's the most commonly diagnosed vestibular problem. In fact, 50% of individuals over the age of 65 may experience some episode of BPPV at some time. The characteristics of BPPV are that it's the actual sensation of vertigo is very short-lived. It's usually seconds to about a minute of the acute episode of vertigo. That's not to say that following that, individuals may still have a sensation of dizziness that lasts for sometimes days, especially with changes in position. Very typically, BPPV comes on, people will notice it first thing in the morning getting out of bed because it's that rolling from side to side, or that movement from laying down to sitting up, or vice versa, that movement of the head which facilitates this. So Cheryl talked a little bit about the anatomy of the vestibular system, and when we talk about BPPV, we're concentrating mostly on those semicircular canals. Let's see if I have a better little focus here. So the semicircular canals right here, okay, and that otolith organ where we have crystals, okay, those calcium carbonate crystals. So the normally occurring crystals are in that otolith organ there, right, in that utricle and that saccule there. And when they're there, it's fine. They help to sense gravity, as Cheryl already told us all, help to keep us upright against the force of gravity. And sometimes those crystals that are sitting on top of hair cells in the utricle, they get dislodged for some reason. They're actually held there by like a little gelatinous-like substance, and part of the reason sometimes for them getting dislodged is that substance breaks down and decays over time. Another reason for it being so common in an older population. So normally, if those crystals get dislodged, what happens is they fall to the bottom. They fall to the bottom of the otolith organ there, and they get dissolved. And no one's ever the wiser. It's just kind of a normal happening. But if coincidentally, while those crystals are falling to the bottom, we happen to move our head in a certain direction, or it's a rapid movement, or we have a trauma, like a fall, that is a trauma to our head or neck, those crystals may not fall to the bottom of the utricle and get dissolved. They may float into our semicircular canal. And that's where we get the problem. Those crystals that belong in the utricle float up into the semicircular canals. Usually, most typically, the anterior or the posterior canal. When they're there, they tend to clump together and get stuck, okay? And now we have a problem. Now there's a problem with the information that's being relayed through this very complex system. Information about where our head is in space that's being relayed through the vestibular nerve to our brain. And now everything's gone haywire in this system that depends on everything to be pretty much balanced. The vestibular system, the oculomotor system, which is our eyes, and our peripheral system, our balance, is all thrown off. So the causes for BPPV, of course, are often unknown. Okay, but some of the things I talked about already in terms of the crystals becoming dislodged because of a degeneration in the substance that holds them to the hair cells, that's thought to be one reason. Certainly trauma, a fall where we hit our head, it's a kind of a rapid back and forth movement of the head, such as in a whiplash injury. These are some common incidences that we can experience this problem. So if we're diagnosed with BPPV, and as Cheryl said, usually it's the dizziness that will bring us either to the emergency room or to our physician, and we'll be diagnosed with the BPPV. Sometimes if we're in the emergency room or even admitted to the hospital because of the degree of the vertigo, you may get some treatment right away there. The diagnosis is usually made through positioning maneuvers of the head and neck. The positioning techniques, we move your head through different positions on the right and the left to diagnose which side is involved. And we watch eye movements, okay? We watch for these involuntary eye movements. Did we bring the Frenzel lenses? Oh, that's okay. And sometimes we'll even put a set of goggles on you so that we can really see these eye movements a little more clearly, because they are a little bit difficult to detect. The eye movements have a technical name. The abnormal eye movements called nystagmus, okay? And usually there's a rotational component to it. And depending upon which way, which direction the rotational component is happening in, that gives us information about how we're going to treat the problem. So through the positioning maneuvers, we determine which side and which canal is involved, and then we can do repositioning maneuvers with the head and neck to help move those crystals out of the semicircular canal and back into the utricle. Let's see. I got a little. There we go. Okay, just to show. So this is a person in the upright position, and it's showing the orientation of your semicircular canals, and it's focusing mostly on the posterior and the anterior canals, okay? And we can see that there's a particle, okay, or a clump of crystals in the canal here. And as the person, this is looking at the right side, okay, as the person is laid down onto their back, their head is in a rotation to the right and a little bit of extension, and you can see just by going into that position, we're now starting to move that crystal from here over to here, okay? The next step, after being in this position for a period of time, would be to turn the head to the opposite side, and again we can see more movement of the crystals. They've gone from here to now here. And then in a side-lying position is when the crystal comes full circle and comes back into the utricle, which is where we want it, so it can fall to the bottom and dissolve. So that's the basic treatment for the BPPV. Sometimes people come in and in just 1 or 2 sessions, we can do a repositioning technique and all is well. Other times, people continue to have symptoms a little bit, down the road, and so they need to come to physical therapy for a little bit of an extended period of time to work on some of the other things that Cheryl was talking about in terms of stabilizing the oculomotor system so that we can focus our gaze on a target. And also incorporating our balance system, our peripheral system, so that we have improved our balance. So it's a very varied kind of approach in terms of the rehab, and it really is very specific to each individual. So we do a complete physical therapy evaluation when you're referred to physical therapy for vestibular rehabilitation. We start by looking at posture and neck range of motion. We will assess your general strength, so we know, what we're dealing with in terms of that. We look at balance, and we do the positional testing and repositioning techniques if they're indicated. Any questions so far on the BPPV? Yes?
Is that therapy for just that episode? I mean, in other words, am I right that it's not a cure for vertigo, like if you have a future? I mean, like if I experience vertigo and I come in for that therapy?
Well, if it's in relationship to specifically the BPPV diagnosis, typically this treatment is the approach. Yes, but there are many other causes, vestibular causes of vertigo as well.
So you could come in and have that, but that's not to say that you wouldn't experience vertigo again in the future. I guess I'm trying to figure out, because when I had one of my episodes, my internist said that the therapy that they had would help me for that one particular episode, but that's not to say.
If you were to have another episode down the road.
I wouldn't even be able to drive myself to the doctor to have that done. Do you know what I mean?
Mm-hmm.
Because when I get the vertigo, it's so bad.
Right.
That I couldn't even.
Well, that's a good point. And in fact, many times we encourage people to come to the first several sessions with another person that can drive you, because the positional testing and the repositioning technique itself can cause some of the symptoms as well. So, and some of the exercises too. So that's a very good point, that you would need someone to drive you in a very acute episode.
Right, but you're saying that some people might not have a problem after having something, the therapy, like they might not have a.
They might not have repeated episodes, no.
Okay.
Sometimes it's just not necessarily a chronic problem in relation to the BPPV.
Mm-hmm.
Not necessarily. Yes?
You said the crystals have a function, right? What happens when they're all dissolved? Are they replaced?
Well, they wouldn't all dissolve all at once. I mean, yes, and they are, kind of generated in the otolith organ, but they don't all dislodge from the hair cells. We're just saying, in the event that they do dislodge, they would normally fall to the bottom and get dissolved and not be a problem. It's when they float into the semicircular canals that they become a problem in terms of the vertigo. And they wouldn't all be flowing. There's hundreds of thousands of them. Yes, they're tiny, tiny, tiny. Yes?
I know a number of years ago when I first was diagnosed with it, I went through the PT, not here but up at UMass, and I had it was a challenge when I went through it. And I think I went through it twice at least. They said, well, go home and do the exercises. Then I would do it, start to feel better. Well, a couple of years or so go by, and next thing you know, I don't sleep on my left side at all. There's certain things I don't do. Unfortunately, I just start getting used to it, but I'm thinking maybe I should really power myself into really doing something here about it. For the exercises, I don't know.
Yeah, that's definitely true. I mean, to help the system accommodate to, as Cheryl was saying, sometimes we give you exercises that repeatedly put you into these positions, and that way the vestibular system adapts.
Some of us just take longer, or might take the rest of our life, huh? It might take that long?
Some people get resolution fairly quickly, but I think the longer it goes on, of course, the harder it is to get relief, definitely.
Get the guts up to keep
Any other questions? BPPV? Okay, so another commonly diagnosed problem is vestibular neuritis and labyrinthitis. It's the second most commonly diagnosed vestibular problem. Typically the result of a viral infection in the inner ear. Sometimes this occurs a week or two after we've had a cold or a flu. The characteristics, again, are a sudden onset. Okay, so people might wake up with it even. But these symptoms of vertigo last longer than the BPPV symptoms. The BPPV, which is that acute spinning, is seconds to about a minute. This is longer, may last for days to weeks, can be mild to severe. This is often accompanied by nausea, vomiting, and decreased balance. Okay. The initial bout of vertigo can last 24 to 72 hours with neuritis or labyrinthitis. But it usually is followed or can be followed by some persistent dizziness, which we've already talked about the difference between the vertigo, which is room spinning sort of a sensation, and the dizziness, which is more of a sensation of lightheadedness, fogginess, not feeling quite right. Okay? However, with the neuritis and the labyrinthitis, after a couple of weeks, people think they're on the road to recovery, and they get hit with another bout of the vertigo. Okay? So that can happen. So how this happens is the virus causes inflammation in the nerve, the vestibular nerve. Okay, so we have here our semicircular canals, our cochlea, which is our hearing apparatus, and then we have our vestibular nerve here, which we can see sends fibers and impulses up to our brain. Okay? So when inflammation happens in this vestibular nerve, as you can imagine, the information that's coming from the vestibular system being transmitted to the brain is going to be kind of disrupted. Okay? So the brain is not going to be receiving the proper input from the vestibular system about where our head is in space. Okay? This is going to result in vertigo and a difficulty with keeping the eyes focused on a target when the head is moving. So the labyrinthitis, we talked a little bit about the neuritis. Vestibular neuritis is in the nerve. The labyrinthitis is an inflammation more in the labyrinth. Okay? But they're basically treated the same from a medical standpoint. In the early stages, if they're caught early in the first couple of days, the doctor may prescribe medications for you to help control the nausea and the dizziness, and possibly even steroids to help decrease inflammation in the nerve. Okay. Usually this is followed up. Oh, sure. Hi.
How does the doctor know the difference between the two if you can't see in the ear?
Well, again, that's the history. Okay. That's why it's so important for the patient to give a good history in terms of how long the vertigo has lasted. These point the doctor in terms of a clinical evaluation in terms of where we might go with all of this. And then the other testing that Cheryl already talked about, the electronystagnogram, all of this information is going to compile into the differential diagnosis for the physician. Does that make sense? Okay. Yes?
Speaking of history, is there a genetic link to cellular disorders?
Not that I know of, not genetic specifically.
Not really.
I mean, if you have recurring episodes, it's not familial in any way or tied to a family member, from a prior generation or something like that?
Not necessarily.
Not necessarily, no.
My father had it, I got it. Yeah, real.
Yeah, I think the vestibular disorders are a lot more common than we think. It's the sort of situation where once you have it and you start talking about it, you find out about so many more people who have experienced problems with the vestibular system. But that I know of, I don't think there is a specific genetic or familial link.
One more question.
Sure.
How do you tie migraines into this? I mean, it seems like a lot of the symptoms of migraine. Is there such thing as migraines?
That's one of the reasons why all these vestibular problems are so difficult to diagnose, because they're all so closely related.
Right.
So it's very, and as we go through and talk about some of the other ones, you'll see that some of the symptoms are closely related and very similar, but there's often one discerning characteristic that sets the different diagnoses apart. But definitely a connection with migraines.
You hear a lot about, a lot of people that suffer from migraines have a lot of these symptoms as well.
Yes. Yeah, it's very confusing and very complicated. And when we go a little bit further on, we'll talk about cervicogenic causes of vertigo as well, problems with the neck. Okay, any other questions right now? Okay. So where was I now? Okay. Oh, so the treatment in terms of decreasing the inflammation, followed up by vestibular rehab, typically concentration on balance activities, gait activities, and again, the gaze stabilization exercises, helping to retrain the oculomotor system to focus on a target. Okay. Okay. So Meniere's syndrome is another commonly diagnosed vestibular problem that people may have heard of. And this is different because it's more of a chronic disorder. These other disorders that we've talked about already have been more of an acute episode. And for the most part, once those acute episodes are resolved, they're done, especially with the neuritis and the labyrinthitis. Those don't tend to recur. Meniere's syndrome is chronic, and the episodes are definitely recurrent, and they recur very, very unpredictably. Okay? So it's a chronic disorder. Again, not well understood in the terms of the cause of it. But it's thought to be characterized by an increase in the volume of fluid in the inner ear. Okay? That increase in volume of fluid creates pressure or fullness, a sensation of pressure or fullness in the ear. And that interferes with the information, again, being sent from the vestibular system along that vestibular nerve up to the brain. So these acute symptoms with Meniere's syndrome now are lasting from 20 minutes to 18 hours, okay, 18 to 24 hours. They can be mild to severe. Where it's recurrent, sometimes people begin to have like a warning sign, which includes the pressure in the ear, sometimes a loss of hearing or a decrease in hearing, or tinnitus, which is a ringing in the ear. These can all be warning signs in terms of the Meniere's syndrome attack, and a decrease in balance as well. So these symptoms usually also come on suddenly as well, okay? But you can see that, we're already starting to get differentiating symptoms like hearing loss, which really wasn't present in the BPPV or the neuritis, okay? So the symptoms with Meniere's disease resolve sometimes completely over a matter of days to weeks, but it is a chronic problem in terms of you get some relief, you get some resolution to the symptoms, and then at any time, could be days, it could be weeks, it could be months, there'll be another occurrence, okay? And this repeated assault kind of on the vestibular system often results in Meniere's syndrome in a permanent loss of hearing and vestibular function. So that's way down the road, though. That's after a long time of having these repeated attacks of vertigo. So treatment-wise, it's usually more of a medical management with Meniere's syndrome. That's usually aimed at medication to help control the symptoms of during acute episodes of the dizziness and the nausea. Sometimes diet has been used in order to try to control these attacks. It's felt that a diet low in salt or sugar, lower in salt or sugar, can help stabilize the levels of sodium and potassium in the system, which has an effect on the control of fluid. So that's another area that sometimes can be used to help control the Meniere's attacks. Vestibular rehab also sometimes becomes involved, again, to address problems of balance, mobility, safety, education, all that kind of thing, where this is more of a chronic problem, you know, prevention of falls, etc. Any questions on the Meniere's? Okay. All right. So another diagnosis, acoustic neuroma. Okay. A neuroma is a benign tumor involving a nerve, in this case the vestibular nerve. This happens to be a neuroma that's located on the covering of the vestibular nerve. And so as the neuroma grows, and it's oftentimes a very slow-growing neuroma or tumor, it puts pressure on the vestibular nerve. And again, that's going to impact how information gets delivered from your vestibular system, from those semicircular canals, from those otolith organs, to the brain. Just going back to, maybe I can just see it here, the vestibular nerve, again, coming from the otolith organ and the semicircular canals, also has a segment that comes from the cochlea, okay, which is our hearing apparatus. So the acoustic neuroma, which puts pressure on the vestibulocochlear nerve, one of the primary symptoms is loss of hearing with this, okay? So, and that's typically loss of hearing and loss of balance, which brings one of these types of patients into the doctor's office. And it's the loss of hearing that would have the physician order probably a hearing test. And then the results of the hearing test are going to point the physician in the direction of having more testing done, usually in the form of an MRI, which then is going to identify the neuroma or the tumor on the nerve. So that's the diagnostic process that goes along with that. Now, these very slow-growing tumors, usually if they're caught early on, the treatment primarily is to monitor the growth of the tumor. And that's usually done through serial MRI. So at different points in time, the physician will have you go back in and have another MRI done so they can tell how the tumor is progressing. If it gets to the point that the tumor is grown to the extent that it's pressing on the nerve to the degree that the hearing is, severely impacted and balance is severely impacted, it may require surgical removal. And depending upon the type of procedure that's done to remove the tumor, then there may or may not be vestibular rehabilitation required after the surgical procedure. And again, that's going to be focused primarily on balance and also on gaze stabilization to kind of recruit that oculomotor system again to help with the balance, because there'll be a definite deficit on that side in terms of loss of vestibular function and loss of hearing. Any questions? Yes?
Yeah, would you see a neurologist or neurologist for this?
Generally, you may end up going to, because you have ear hearing loss first, you might end up going to your primary physician, who would probably send you to an ENT. But the ENT, once getting the results from the audiogram or the hearing test, might refer you on to a special ENT who specializes in these types of diagnoses, a neurootologist. Yes? With the neuroma? Most of them are really sudden onset. The biggest thing with the neuroma is the hearing loss. And I actually had a patient, I've had 1 or 2 patients after a neuroma, and one patient was very interesting because she had hearing loss for a very, very long time. And she just thought it was, she always had a hard time hearing out of that one ear. But all the while, it was the neuroma. It was, she had at one point a very sudden, couldn't hear anymore out of that ear. That brought her in, and she ended up with the diagnosis of the neuroma. So no, most of these are really sudden onset. Yeah, yeah. I mean, the Meniere's, after the initial incidences, you get these warning signs because you learn that, okay, I'm getting a pressure or a fullness in my ear, or I feel a little off balance today. Maybe there's an attack coming on, but not at the beginning stages, no. Any other questions? Okay. The last category we're going to talk about is cervicogenic dizziness. And this is not really a vestibular problem in the sense that we've been talking about vestibular problems with the semicircular canals or the nerve in specific being affected. They're usually muscular and postural issues emanating from the upper part of your neck or the upper cervical spine. Sometimes associated with headaches or neck pain or tenderness around the muscles of the neck. It's usually not a diagnosis that's made until all other sources for vertigo or dizziness are ruled out. And it's probably not really even commonly regarded probably among physicians. It's probably more the physical therapy community that's finding more and more relationships between dysfunctions in the upper cervical spine and the onset of symptoms of vertigo or dizziness. So usually the symptoms with cervicogenic dizziness are a little different. There can be room spinning vertigo. There are patients out there who have room spinning vertigo, but more likely it's more of the dizziness, the lightheadedness, this feeling of not feeling quite balanced. The causes of it can be varied, just like with everything else. Either traumatic, a head or a neck injury, or degenerative due to arthritis in the spine or disc disease in the spine, or even chronic postural changes. Okay, so, all right, so we've talked all about this, all these other sources of vertigo in terms of the inner ear. How would the neck possibly cause vertigo? And the connection is that there are nerve receptors in the neck, in the upper neck, that connect with the vestibular system. Receptors in the neck tell us where our head is positioned in space, just as the rest of the vestibular system does, the oculomotor system does. So what happens is that when we have a neck injury, the information coming from the neck doesn't quite match up with the information that's coming from the semicircular canals or from the eyes even. For instance, think of if you had a very stiff neck and you were kind of stuck in a side bend position. Well, the neck would be telling you, the neck receptors are telling your brain that this is normal, this is upright. And the vestibular system is telling your brain, and your eyes are telling your brain, no, this isn't normal. So there's this kind of disconnect in information going up through our pathways to the brain, and this results in the dizzy symptoms. Okay. So what kind of treatment do we do for cervicogenic dizziness? This is more of a manual approach. The physical therapist will be working on the neck to try to decrease muscle spasm, to decrease muscle tightness, to normalize the joint mechanics in the cervical spine so we can have normal, full range of motion in the cervical spine, to correct posture and to strengthen the appropriate postural muscles. So that's the approach with cervicogenic dizziness. Questions? Nope. Okay. So again, Cheryl's already reviewed all the red flags of sudden loss of balance and ataxia, sudden vertigo that doesn't resolve in 4 hours, dizziness associated with loss of sensation, loss of strength, or slurred speech, all things that would tell us this is a serious situation, we need to get this attended to. So in conclusion, vestibular rehab is a specialized branch of physical therapy. The focus is an exercise-based approach, okay, in which we try to relieve the symptoms of vertigo or dizziness by helping the body adapt to and substitute for the loss in the vestibular system. The therapy is going to address the primary complaint of dizziness or decreased balance, as well as any secondary conditions that may arise, such as headache, neck pain, a decrease in your functional mobility, or a decrease in endurance and strength. Depending on the source of the problem, your treatment's going to be varied. It could be repositioning techniques, as with the BPPV. It could be balance, gait, eye exercises, or it can be treatment to the head and neck. So it's important to realize that during your course of vestibular rehab, that you may initially have an increase in your symptoms, and this can be very normal because we're going to be really challenging the system and maybe putting you into positions that provoke your dizzy or vertigo symptoms. It's also important to know that as you progress through the rehab course, it's not always a smooth uphill climb. Sometimes it's a little bit of ups and downs. So you may have periods where you are symptom-free, followed by periods where you have some return of symptoms. But over time, overall, the symptom-free periods increase while your symptoms are decreasing. So we thank you all for coming out tonight and listening to our presentation. Any other questions? What's that? Okay, so yes, so just one more thing. This is where we all want to be, doing our normal daily activities in a completely balanced fashion.